Dr. John D. Carroll is currently Professor of Medicine, Director of the Cardiac and Vascular Center, and Chief of Interventional Cardiology at the University of Colorado Hospital. Dr. Carroll performs structural, coronary, congenital, and valvular therapeutic procedures. His research involves therapies of heart valves and cardiac imaging modalities, including many cardiac clinical trials. He has received many research awards. He's also obtained 3 U.S. patents. He's published about 200 peer-reviewed articles, 5 books, and over 270 presentations worldwide. And his topic today is the role of real-time 3D TEE integration for complex transcatheter SHD repairs. So please help us welcome Dr. Carroll. Thanks for being here.
Thank you. Testing. This is a very diverse program, so we're going to move on to a topic, an interventional topic, specifically the image guidance of interventions and how this is really undergoing a major transformation. In terms of disclosures, but also in terms of collaboration and the work of many people in the medical device and medical imaging industry really needs to be acknowledged, especially with the work I'm going to be presenting. If there is really a conflict of interest I have, it's in marketing a textbook of mine with Dr. John Webb in Vancouver. So structural heart disease interventions are really blossoming in the last decade and picking up speed with a variety of new interventions. And the determinants of success are multifactorial, and involves not only choosing the right patient and getting a correct device in that's skillfully placed by a team, but then there's also the key ingredient of imaging for guidance. And certainly in the last 10 years, we've seen how device design and the ability to put devices in goes along with the imaging by which we can guide it. Better imaging then allows the engineers in the device industry to design new kinds of devices that utilize the new kinds of imaging. So it's a real iterative process. And with structural heart disease interventions, we certainly have gone from the days of simply having plain old fluoroscopy along with 2D ultrasound to having 3-dimensional. And that's really broadened our understanding of a variety of issues of not only putting the device in, but also looking at the interaction of devices with anatomy. And the structural heart disease space is really characterized by very unique devices for the first time going into the regions of the heart that devices have not previously been, and a lot of unpredictable things. Sometimes the device loses and it fractures. Sometimes the patient, the anatomy loses, and you have things like device erosion. Again, really facilitated by this new approach to imaging. That involves often ultrasound and now 3D flavors, such that we're really looking at the deployment of devices in 3D space. And that really helps in the world of structural heart disease because we're talking about alignment of devices in 3D space, something that we really didn't have to worry about in the same way with coronary and vascular interventions. In addition, I think the advances of imaging have shown that with these 3D echo data sets, that the perspective that can be created, that can be presented to the physician, to the team, can be independent of where the imaging device is located. With fluoro, the image is produced via the FACC detector. With ultrasound, TEE specifically, we're used to the image being from the perspective of the esophagus. But with 3D data sets now, you can turn that around as shown here. You can have the typical left atrial view from a transesophageal probe, but you also can turn around the data set and look from the left ventricular side, allowing us to really understand these various steps and facilitate these tasks that have to be performed in putting in a mitral clip for the treatment of severe mitral regurgitation. So ultrasound guidance for structural heart disease really has a variety of advantages, and the ones that are highlighted here in blue are the soft tissue visualization in real time. You know, we're used to interventions having real-time fluoro, but using real-time ultrasound with soft tissue visualization is key for many structural heart disease interventions and other system and modality advantages. And then there are disadvantages, and we'll see some examples of the artifacts that can be produced. Also, the perspectives may not be intuitively useful for interventions. Again, where does ultrasound come from? It comes from the diagnostic world. That's where it was perfected. That's where the technology was refined, and a lot of the tools within it are diagnostic, and the perspectives are diagnostic. Likewise, there are challenges in terms of highlighting again that ultrasound has really been poorly integrated into the procedure room, and for us to move on in a new generation of procedure rooms and perform additional interventions, we have to relook at that. So optimizing image guidance for structural heart disease involves certainly real-time imaging. You don't go down and review images later. You're actually acquiring them, interpreting them, and acting on them in real time, and that's where both X-ray and ultrasound are essential for the structural heart disease interventions. And we've seen this transition to 3D visualization with ultrasound particularly that complements, is not an alternative or replacement technology, but complements 2D. But this is where we're at right now in terms of image guidance in structural heart disease. Where do we want to go next? What needs might we have? So let's talk about 4 features that if we sat down over a beer and thought, hey, how can we make this better? What can we do to design image guidance that really will allow us to more effectively, efficiently perform these interventions? First of all, we need to have the imaging modalities embedded, be them ultrasound, be them pre-procedure CTs. We got to get away from the paradigm of rolling in echo machines and rolling them out. We know that's very inefficient, and we've seen that with the way IVUS really got revolutionized once it became a plug-and-play in the procedure room. Secondly, interactive. Look at the way the history of intervention started using only X-ray. We're used to controlling that. We turn it on, we turn it off. We have a tableside controls that allow us to do a variety of things, of magnifying, of changing the perspective. So we have to have interactivity with any kind of image guidance. And fluoro remains a primary image guidance. Adding echo means it has to be integrated, and we'll see some thoughts on how that can be done. And secondly, it is all about performing interventions, not doing diagnostic, and therefore talking about the formats, the target identification, the perspectives useful for performing that. So I'm going to show a few examples that come from our experience in the last year or so with a variety of structural heart disease interventions. Tomorrow there's going to be a great presentation I'll come to later that will go into more detail. This shows an image where a lot of the brainstorming in this kind of project started. And this is a TE image, 3D obviously, of a left atrial appendage. So it's from the view of the esophagus, but you're changing perspectives. And what happened with the advent of 3D TEE is that after the procedure, sitting down at a workstation, you were able to really review the anatomy and the intervention after the fact, but still you had control of the image, you had control of the perspective. And not only do you see how inherently one can become more familiar with the anatomical structure, but how one might start thinking about what kind of device, how would I put this in. So it really started to show that with the improved visualization and understanding of anatomy devices that came along with having the ability to control the image. So let's translate that into tableside controls of 3D ultrasound. So in this panel, what we're seeing is the ability to enlarge or shrink the image, to pan it, and to turn it. So this is after a transeptal catheterization has been performed, and we're down here using the mouse to change the perspective and to really understand where we're at in this intervention. Where did we puncture the septum primum relative to the whole intraatrial septum. What is the trajectory of the transeptal catheter? And notice that if you have control of that as an interventionalist, you're really able to understand what you're doing, what you've done, and what you want to subsequently do. So you're not simply relying on the view that the echocardiographer gives you, but you're able to determine that view, and that's a kind of interactivity in tableside controls we need. Next, you can not only put up one view of a structure, and here we have an ASD device still with its attachment, but you can simultaneously see it from different views. So rather than relying on your colleague to give you the various views sequentially, you can simultaneously get them, and that inherently helps the efficiency of performing certain interventions. So what about integration of X-ray and ultrasound to perform structural heart disease interventions? And one form of integration is registration, which means you take two modalities and try to match them. Same scale, same perspective, and that's done in other modalities. And here we're talking about ultrasound and X-ray. We want to align the two, and we'll come to how that might be useful and is useful. So a very innovative approach is rather than finding common anatomical landmarks that are seen in fluoro and in ultrasound, why not just in X-ray align the TEE probe such that you get this so-called 2D, 3D image-based registration, and you align the probe and you know where that 3D TEE ultrasound data set will look, where it will lie in X-ray space, so to speak. And the way we do this registration is you just simply do two views of the probe, an RAO and an LAO, arbitrary angles exactly, but this kind of then registration of that probe then allows you to align the X-ray and ultrasound images in the following way. So this is a view of the intraatrial septum, and here's the X-ray view, and the X-ray view going from LAO 25 to RAO 6. What is the parallel ultrasound view that corresponds to that X-ray? And we can see here the intraatrial septum. As we turn the gantry, we're getting this different view of the intraatrial septum with with a lot of echo dropout of the septum primum, and so you really can see how this creates new views that we're not used to, knowing what the soft tissue is. Specifically, like when you're doing a transeptal, often you're in an AP view, but you would like to know in that patient-specific way, what is the plane of the septum? And my colleague, Ernesto Salcedo, the head of the Echo Lab, said to me, well, I can give you that same view of in the 3D data set that you normally use for a transeptal, a straight AP. And he produced this image, and that really helped start us on thinking of how can we really harmonize the two imaging modalities, and how can we use it for performing certain interventions, be it the beginning of a transeptal here. So what value does that bring? So it really makes fluoroscopy guidance much more smart. For example, this is a prosthetic mitral valve with a paravalvular leak. We're going to perform a paravalvular leak closure. We see in the ultrasound, only in the ultrasound, where that paravalvular leak is and the perspective. And wouldn't it be good to have an X-ray view where we really know where that paravalvular leak is? So by getting the registration of these two modalities, one can bring that together and make the fluoroscopy, make that view of the paravalvular leak much more appropriate for performing an intervention. Next, how can we help understand what's going on in the 3D TEE images versus getting lost in 3D space? Well, now there's the technology available to put markers, to put labels in these 3D data sets so we can get some orientation. where the aortic valve is, where the SVC is, and also the target. So we can put the target around this ASD we're about to close, and so this is really a new world that allows communication amongst the team, so we all know what's going on, and orientation in the images. And currently some disadvantages in that this is fixed in space, but we know with ultrasound tagging that we can put a tag on an anatomical structure, and despite the beating, it can be followed. So that will be, I think, a next generation. So finally, let's put this all together. So here's a TE view of the left atrium, and we're looking here at the appendage, and we're going to close this appendage, and I'm putting a marker on the os of the left atrial appendage. So I'm rolling it around to make sure this marker, this targeting, is correctly placed in the os, and seeing here both in the straight view and from the esophagus, but also in this view that I'm able to turn around. And then what we can do is we can then turn on the X-ray, and notice this is going to show the registration of the model of the TE probe, and this is where the 3D data set will occur. And now, based on this soft tissue marking, I now know where the left atrial appendage os is in X-ray. Notice how it's making the X-ray visualization with this targeting much more intelligent, so to speak. So, in conclusions, these integrated guidance systems, specifically for the interventional lab, are being developed and really to enhance the performance of these procedures with multiple benefits: enhanced understanding of the anatomy and the intervention, improved guidance, navigation and catheters, wires, streamline this 3D alignment of devices and structures, accelerate the assessment of the results, because there I'm immediately able to turn around the device and look at it from multiple viewing. And a lot of these are team performances, and so it really enhances the communication. And tomorrow, Stacy will be presenting more on our own experience in the imaging and TAVR session. Thank you.
Thank you very much, Dr. Carroll. Ladies and gentlemen, we do have time for a couple of questions. Bring you the microphone. Here you go.
Thank you for a really excellent talk. I was wondering if you could give some more specific examples of what is equivalent in TEE to an RAO view or an AP view or an LAO view. Are there any specific examples, or is that not what you're talking about exactly?
So I think what one finds when you integrate the ultrasound or register ultrasound and X-ray and go back to your typical RAO, LAO views is you really get a very patient-specific understanding of the orientation of the heart and the soft tissue structures in these X-ray views. I think a good example is when you're doing an ASD or a PFO closure. The plane of the intra-atrial septum is not consistent across different patients. It's often extremely variable, and by doing this sort of registration, you start understanding that in a patient-specific way, and that leads to very specific things, like in closing large ASDs, having a delivery catheter that's the right shape, sometimes with the extra posterior bend in some of these, that fits that heart, so when you deploy the left atrial disc, you are well aligned with a defect versus being out of line. So I think that's another example of the way of registering ultrasound and X-ray and getting the same perspective helps. I think potentially it also will cut down on getting confused, because if you think of the view from the esophagus versus a fluoro view, what has to go on in your mind is you have to understand, you have to integrate those two very different perspectives of the same structure, and this gets it more concordant. So there may be less visual confusion, less hand-eye coordination mismatch, because most of the time when we're doing interventions and we're using our hands to move devices. We're using the X-ray view because that's what we're used to. That's what we're kind of registered to. But this allows that to occur in ultrasound.